So, ma'am, it's 3, 2, 1. Over to you, ma'am.
Very good afternoon and warm welcome. My name is Dr. Charmi Prajapati and I am from Macleods Pharmaceutical and part of Medical Affairs team. So as we all know that prevalence of diabetes is increasing worldwide and India has second highest diabetic population in the world followed by China. So the topic for today's session is controlling diabetes and cardiometabolic risk with the combination of SGLT2 inhibitors and DPP4 inhibitors. So in order to understand the topic and go deeper into it, we have with us Dr. Bhaskar Shah as our esteemed speaker for the day. Next slide. Doctor is currently Director of Cardiology, Consultant and Interventional Cardiologist at Jupiter Hospital, Mumbai. Previously served as Director, Founder Member, Consultant and Interventional Cardiologist at Asian Heart Institute and Research Center. Sir has more than 30 years of clinical experience. Sir has expertise in invasive cardiac techniques and has independently performed 10,000 cardiac catheterization, including coronary angiography. Sir has independently performed 2,500 coronary angioplasty with special interest in complex coronary angioplasty in elderly patients above 25 years of age, and multi-vessel coronary angioplasty. Sir has also chaired and delivered multiple presentations at national and international symposium and conferences. It's an honor to have you, sir. I hand over the session to you.
Good afternoon. Thank you, Dr. Charmi, for a kind introduction. And without wasting any time, we'll go to the topic proper. Let me just share the screen before we start. Good afternoon, friends. I'm going to today speak on vildagliptin and dapagliflozin combination for control of diabetes and cardiometabolic risk. As we all know, India in 2020-21, it accounts for about 1 in 7 of all the diabetics worldwide. And that why obviously was known also as capital city of diabetes. It is the second highest country with DM prevalence, just next to China. And we had about 74.2 million diabetics in 2021. It's also important to know that effective, good long-term glycemic control is absolutely mandatory and essential to improve the outcome. 1% decrease in hemoglobin A1C translates to 43% reduction in amputation or fatal peripheral vascular disease, 37% decrease in microvascular disease, 19% reduction in cataract extraction, 16% less heart failures, 14% less myocardial
Bhaskar sir, sorry for interruption. Can you please hide this video? It is overlapping. The Zoom video is overlapping. Can you please hide this? You can swipe on the video and it will be hide, which is coming over your PPT, sir. Okay,
Now,
perfect. Thank you.
And 12% reduction in the incidence of stroke. We all know about the ominous octet for hyperglycemia. We all know that there are 8 major instrumental factors for hyperglycemia, starting from decreased incretin effect, or which started with impaired insulin secretion because of beta cell dysfunction. There might be increased glucagon secretion leading to hyperglycemia. Liver might be producing much more glucose than necessary, or increased hepatic glucose production. Fault in the neurotransmitter, decreased muscle uptake by the muscle, glucose uptake by the muscle, increased glucose reabsorption by the kidney, and increased lipolysis. That means hyperglycemia is multifactorial. And if you can control more factors, better and effective will be the control of hyperglycemia. Let us first understand the DPP4 inhibition, mechanism of action of DPP4 inhibitor. What are food we take through the intestine? So it's the food absorbed. We have formation of active GLP-1, which in turn stimulates pancreas to secrete beta cell stimulation, leading to increased insulin secretion, which is glucose dependent, and this in turn causes control of blood sugar because it increases glucose utilization by the muscles and adipose tissue. It also has a negative effect on alpha cell. There's a glucagon suppression, and this in turn causes decreased hepatic glucose release, improving the overall glucose control. So this is exactly how GLP-1 acts through stimulation of beta cell, inhibition of alpha cell, decreased glucagon suppression, increased insulin secretion, and overall better utilization. This GLP-1, in presence of DPP4, is inactivated to inactive GLP-1, and all these actions will go away in a short time. When you give DPP4 inhibitor, the active GLP-1 is not inactivated by this DPP4, and therefore active GLP-1 is available much more longer time, leading to better action of beta cell and negate the action of glucagon. So this is how DPP4 inhibitor acts, by increasing the level of active GLP-1 by preventing its inactivation to GLP or to inactive GLP. Similarly, if you look at glucose reabsorption in BP, more than 90% of glucose is reabsorbed from the glomerular filter into the epithelial cell by this SGLT2 enzyme. And if you give SGLT2 inhibitors, this glucose reabsorption is prevented, larger number of glucose goes to the kidney, and you have increased glycosuria, leading to better glucose control. Important to remember over here, there is a threshold at which this happens, and that is usually above 180 milligrams percent. If this is below, the blood sugar is below 180 milligrams percent, this would not happen. Therefore, this drug in a patient who is non-diabetic would not get this effect to the level what you would get in a patient who is diabetic. So SGLT2 inhibitors essentially, as I showed in the previous diagram, causes glucosuria, which will cause loss of energy because you're losing about 80 grams of glucose in the urine with this, leading to decreased weight, increased lipolysis, increased gluconeogenesis, and all these things will prevent fatty liver or non-alcoholic steatohepatitis. This also causes increased ketone bodies going to the heart, and you get metabolism, which is more effective and more useful for the heart, and thereby improves the cardiac function. It also, through its total body sodium and hydrogen excess, through this sodium hydrogen exchanger, one transporter acts on the heart, and all that thing will ultimately lead to reduction of heart failure. It also neutralizes, directly decreases fibrosis through this NHE3 mechanism, and it also controls. The three most important mechanisms are decrease in weight because of decrease in sodium and water, or nitriuresis, which is more fluid which is lost, less of electrolyte getting lost, leading to decreased volume and thereby helping cardiac failure and hypertension. And by calorie loss, there is weight loss. There is weight loss, control of blood sugar, and high blood pressure. There is also increased hematocrit, and it protects kidney. Overall, this multiple pleiotropic action, it causes increased ketone body production and metabolism, decrease myocardial sodium potassium exchanger, and neutralizing the effect, causes increased glycemic control, which in turn causes increased endothelial functions improvement, vascular stiffness goes down, blood pressure goes down, plasma volume decreases because sodium, as I told you, there is free water clearance, hematocrit goes up, plasma uric acid level goes down, nitriuresis, and more important, it decreases intrahumeral filtration and thereby prevents albuminuria. The next effect is increased glycosuria, decreased albuminuria. As I told you in the previous slide, there is decreased fatty liver, decreased skin sodium content, decreased body mass, leptin production, and decreased age race signal. Essentially, there are multiple benefits and pleiotropic action of SGLT2 inhibitor. And because of this, if you really look at the guidelines, ADA 2022 guidelines, very clearly says that now SGLT2 inhibitor has become one of the predominant drugs, one of the first important drugs, maybe with metformin or maybe just after metformin, according to some authorities, even before metformin, in a patient with primary cardiovascular or renal involvement. So essentially, as I can show you here, the recommended independent vigilant events included essentially with ASCVD indicated of high risk or heart failure or CKD. That is where it is important to see that the drug has been very strongly advocated for patients with cardiovascular disease, which is atherosclerotic, or heart failure, or patient with multiple risk factors, or CKD. That is where, secondly, if you look at it, DPP4 inhibitors, especially because it is weight neutral, minimize hypoglycemia. As you know, we want drugs which are primarily not going to cause weight increase, and that is where DPP4 is. SGLT2 will on the contrary cause weight loss, so both will be very useful. And both of them, that is DPP4 inhibitor and SGLT2 inhibitor, the incidence of hypoglycemia is extremely low. And therefore, the combination would be extremely useful. If you look at DPP4 inhibitor given in BD dose, and if you look at OD dose, it will very clearly show that there is a linear plot of mean plasma concentration of Vildamac in this specific example, or which is exactly DPP4, what is actual time for case product. That means OD dose works as good as the BD dose. And if you look at mean concentration of DPP4 inhibition also is identical, trying to show that DPP4 inhibitor combination works. I mean, DPP4 inhibitor, a single dose works as good as the dual dose. And similarly, if you look at the weighted average of 24 hours after OD versus the BD dose is identical. And all this very clearly show that Vildagliptin given in the dose of OD 100 milligrams can be used as effectively as BD dose. Once BD dose, not recommended for creatinine clearance is less than 50 ml. And the good part, it can be given with or without weight. So any time of the day, OD dose is good enough. Now we all know that Besides glycemic control, glycemic variability is an extremely important measure of diabetes control and a marker for preventing future major adverse cardiovascular events. And one of the indicator of glycemic variability is MAGE. And you could see here that in a patient, Vildamac reduces glycemic variability baseline versus 6 weeks later, and the standard deviation of 44 glucose also. Therefore, it does both. It decreases glucose and it also reduces glycemic variability. For people who are not aware or who are not concept-wise, glycemic variability, therefore, there is a patient, blood sugar in the morning is 100, afternoon 250, late evening 300, again post dinner 200. Huge variation. That would be a marker of poor long-term prognosis. And what we see here is Vildamac by the marker MAGE very clearly shows that it reduces this glycemic variability. Vildamac also lowers albuminuria in patients with type 2 diabetes. And that is very important, independent of glycemic control. As you could see here, people who are here, better controlled or not controlled, but all of them very clearly see that urinary UACR, which is a marker of albuminuria, is significantly down in Vildamac. That means even in patient where the diabetes may not be well controlled, albuminuria is very well controlled. To look at the overall benefits of Vildamac, I'm going to talk of cardiovascular and heart failure safety, meta-analysis. 40 studies, phase 3 and 4, more than 17,000 patients, 50% with high severe risk, 18% with cardiovascular disease, 40% with renal impairment, and roughly half of them distributed 9,500 patients on Vilda. Other comparator drugs, average age 57, hemoglobin A1C average 8.1, followed up for a period of 5 months, diabetes duration for 5.5 years. Primary composite endpoint, which will look for a non-fatal MI, non-fatal stroke, and CV death, secondary endpoint along with an heart failure events. And what was very clearly seen is that all this MACE composite endpoint, myocardial infarct, stroke, and CV death, all favors Vildamac. That means Vildamac meta has no increase of MACE is extremely important. It's very, very cardiovascular safe drug. Another important worry with DPP4 inhibitors, as you look at in other drugs, was induction of a patient has a higher tendency of going into cardiac failure. And that was for Vildamac, as you can very clearly see, compared to placebo, there is no major change in the ejection fraction. And therefore, you can see that compared to placebo, Vildamac has no major cardiac on LVEF, and therefore there is no increased incidence of cardiac failure, and therefore again it tells you about its cardiac safety. So we very clearly documented this cardiac safety of Vildamac. Looking at dapagliflozin, very classical trial, declared CME 58, very clearly showed that CV death or hospitalization heart failure, when compared with placebo, there was 17% reduction in the incidence of heart failure and p-value 0.005. Renal composite hazard ratio again 0.76. So it is very, very beneficial in reduction of cardiovascular death or hospitalization heart failure. And renal composite endpoints are also significantly reduced with dapagliflozin. And obviously, the rationale for combination of Vilda and Depa. So we have now clearly shown you so far that Vildamac is an extremely effective drug for controlling blood sugar, preventing and reducing glycemic variability and cardiovascular safety. We also showed you that dapagliflozin is extremely useful in reducing cardiac failure, cardiovascular death, and renal composite. Let us see a combination of both. Does it work? So why the combination is important now? As I started the lecture and showed you that there are diabetes or hyperglycemia has multifactorial. And let us say when you use a combination of these 8 factors, what can be controlled? As you could see here with SGLT2 inhibitor, you can increase glucose reabsorption is prevented. And with vildagliptin, as I showed you already, it causes decreased insulin secretion because of beta cell action, increased glucagon secretion or alpha action, and because of the alpha action, it will cause increased gluconeogenesis. So out of these 8 factors, 4 will be effectively well controlled. Number 2, dapagliflozin insulin independent glucose excellence, because as you told me, it works under glomerular, which is not dependent on insulin. Increase glucagon, and at least to increase glucagon and increase glucose uptake. Vildagliptin acts on alpha cell of pancreas, decreases glucagon and decreases glucose uptake. And you can see here now that increased glucagon action neutralize the decreased glucagon, and therefore there is a balance action. Combined with tackle glucagon surge that may occur due to dapagliflozin. That's another synergistic action of dapagliflozin. And obviously, as I showed you, the combination will cause increased glycosuria, that will decrease glucose toxicity. DPP4, as I told you, all these mechanisms of action ultimately causes decrease in hyperglycemia. This will cause SGLT2 besides glycosuria, it causes weight loss, blood pressure going down. This may weight loss. Overall combination will have weight loss, decrease hyperglycemia, decrease weight, decrease tolerability, and a huge synergistic action. Number 2, drugs. Describing the drug twice daily intake compliance, and we have made no doubt about it. The mechanism of certain studies very clearly show that the impact of reducing frequency is there across acute and chronic disease. Reducing usage from multiple to OD may improve the adherence, as this may result in subsequent decrease in healthcare cost. So compliance goes up, synergistic action, and third, both are OD dose with good identical pharmacokinetic and pharmacodynamic profile. Another important benefit of combination is the incidence. We are worried when you're giving SGLT2 inhibitor, the incidence of urinary infections and genital infections are more. But what we found when the combination was given, the incidence went down. So this is because probably the organisms, urinary tract infection organisms, they need DPP4 for their survival. And when you do DPP4 inhibitor, the infection is better controlled or prevented from it. And that brings us to the appropriate use of this combination based on these glycemic factors. What obviously every single patient with diabetes will initiate with lifestyle modification. Down the line, where you use a treatment new patient who have never been on treatment, when metformin is contraindicated, which is supposed to be the first drug, but for some reason you can't give it, or intolerance, and hemoglobin A1C is more than 8, then a combination of DPP4 and SGLT2 can be used. That means the first indication is where people cannot tolerate metformin and the hemoglobin A1C is more than 8, this drug is used. In treatment new, with where now patient we are in starting first time, metformin can be given. But if the hemoglobin A1C is very high, 9, then you can do a triple combination of metformin along with SGLT2 inhibitor and DPP4. And lastly, people are on metformin, not controlled, you can always give this with hemoglobin A1C. This will be indication, 3 subsets of patients. As the primary drug where metformin cannot be given when the hemoglobin A1C is more than 8, when metformin can be given but the hemoglobin A1C is more than 9, when metformin has been given and yet the hemoglobin A1C is more than 8.5, then again a combination. And therefore, friends, if I were to summarize, combination is suitable option for Indian type 2 diabetes mellitus patient because it is a safe, rapid and sustained glycemic action, improves both insulin resistance and beta cell functions, helps reduce body weight and blood pressure, which is extra glycemic effect, reduces pill burden because of OD dose adherence and compliance, and overall cost effective. And therefore, if I were to summarize, I could say that SGLT2 inhibitor and DPP4 inhibitor is an extremely combination for control of diabetes, along with weight neutrality, synergistic action of reducing urinary tract infections, OD dose compliance, cost effective, and essentially a good drug. Thank you, friends. And yes, here I would end my lecture and open for any questions if there are.
Thank you, sir, for the wonderful session. We have few questions here. First is, in clinical practice, what would be the place of this combination? Should it be first line or added as step-up therapy?
There are enough literature details, literature data to tell us that this drug has been getting promoted, and there are guidelines from European Society which say that it can be started even before metformin. But what I would do is, if I have a patient who has a baseline atherosclerotic coronary artery disease, or congestive cardiac failure, or renal involvement, or a patient is very high risk, I would take liberty of starting this first. But yes, there might be people who say that they probably had metformin followed by this. What is important to know is when this patient has all this disease, there are stages where the diabetes is significantly more. And by and large, it's a semantic debate to say this or that. Most of the people will need both. That means DPP4 inhibitor with SGLT inhibitor and metformin.
Thank you, sir. So next question is, how was your experience with Vildagliptin SR?
We have obviously not used it in large number of patients, but in about, I must have used it in about 10 of them. And all that I can say it is extremely effective and as effective as Vildagliptin. And I would have no hesitation in changing over to OD dose because the overall the effect, that means the efficacy and the side effect profile, both are accepted and as good as VD.
Yes, sir. In post-MI patient with diabetes, is this an ideal combination to add?
Yeah, as I told you, any patient of atherosclerotic coronary artery disease, post-MI being one of them, I would very strongly recommend the combination of DPP4 inhibitor with SGLT2. Obviously, there are a lot of contraindications. I mean, the creatinine should be definitely an acceptable range to start with.
All right, sir. In absence of further questions, I think we can conclude the session. And on this note, I would like to thank you for taking a very detailed session and for sharing your clinical experience.
Thank you very much.
Sir, and
thanks again, Macleod once more, and Dr. once more for giving this opportunity.
Thank you.
So we'll leave, okay?
Yes, sir.
So, ma'am, with your permission, shall we end this meeting?
Yes, Kev.
Thank you. So from here, I'm ending this.